Chapter 5. Recovering your arm and hand. While losing your mobility can be devastating, it can be equally frustrating, if not more so, to lose the use of your arm and hand too. Our daily lives seem to require two hands to do just about everything: dressing, washing, cooking, working. We talked with 3 top occupational therapists and researchers to bring you answers about recovering the use of your affected upper extremity, or your arm and your hand. Dr. Mary Ellen Stoikov is a researcher in the area of post-stroke upper limb hemiparesis and a professor at Rush University in Chicago. Dr. Glenn Gillen is a professor at Columbia University who literally wrote the book on stroke rehabilitation, 2 textbooks, and countless other publications. And Dr. Stephen Page leads the Brain Lab as a professor at The Ohio State University and co-developed the Stroke Specialist Certification Program for Rehabilitation Therapists. Question 27. Why is it that the paralyzed arm and hand seem the slowest to recover? Dr. Stoikov. The middle cerebral artery is most commonly affected by stroke, and that artery covers a huge territory in the brain, which includes the area that controls the hand and the arm. We have more cortex area in the brain for controlling the hand and the arm than we have for controlling the leg. The reason is that our hand and arm movement is very sophisticated. It's harder to rehabilitate very complicated movement where lots of joints are involved than it is to rehabilitate walking, which is mostly hip flexion and knee extension. Walking is complicated, but arm movement is much more complicated. An everyday action such as picking up an empty cup requires a lot of movements. First, it requires movement in the shoulder. Then the elbow has to straighten. Next, the forearm has to be placed at the exact angle in order for the hand to position itself and bring the fingers around the cup in the right size and shape. It's not as simple as it might seem. Question 28. What can stroke survivors do to get their hands working again? Dr. Stoikov. One approach I advocate is sensory feedback into the hand. If you don't have movement, I would flood that hand with sensory feedback, rubbing a towel on it, applying vibrations, putting it in uncooked rice. We have connections in the brain that run between the sensory and motor cortices. They're very intricate connections, and sometimes when we massage or stimulate the sensory system, all of a sudden we see movement. We take advantage of the two-way street between the brain and the hand. Even if the hand is not yet ready to move when the brain signals it to, you can put sensation in that hand so that it sends a message back to the brain to strengthen neural connections. An occupational therapist can help you figure out things you can do in your life to get your arm moving. If there's no movement or if the task is unsafe, there may also be one-handed techniques you can learn. But I'm not a fan of starting with those right away. It's use it or lose it. So you really want to try to use your hand to get that part of the brain that's affected by the stroke to work as much as possible. The occupational therapist can help you to learn to use that hand, even if you only use it as a stabilizer. For instance, you can use the affected hand to hold a jar while you open it with the other hand. Or you can use it to stabilize a piece of paper when writing. You can even just place your hand on a faucet and turn your arm to turn on the water, or you can put your hand on a doorknob and open and close it with your arm. Once you take the weight off the arm can move more easily than it would if it were moving against gravity. Even if you don't have hand movement, keep your arm moving to decrease pain. Keeping a limb still is going to cause a pain syndrome. Continue any stretches or exercises you were given, and keep up activity in your life. You may be surprised what helps or happens as you're living your life. I've seen people who got memberships to a fitness center near where I work and come back in later with greatly improved arm movement. Well, it's because they were using some of the weight machines, and the more you use the hand and arm, the more it sends messages to the brain and the more recovery happens. Question 29. Is there a time frame for regaining use of the upper extremity? Dr. Stoikov. The first year is when you have the most chance of getting the movement back, but that does not mean that the movement is not going to come back after the first year. I've seen people in our research studies who got movement back after 5 years. The key is to use your arm as much as possible. But if you've reached a plateau and you want to move on with your life, for example, stop going to therapy or being in research studies, then do that. If you see a change or start to get some movement back, then ask your doctor to give you another referral for occupational therapy based on the new movement that you have. As with all other parts of stroke recovery, age, stroke location, and severity have an impact on upper extremity recovery as well. Younger people tend to do better than elderly stroke survivors. But I would never say that you're going to get movement back because the brain is just too tricky. You may get some movements, but not a fully functional hand. Every little bit helps. Question 30. What is learned non-use? Dr. Gillen. The term learned non-use is usually used to refer to people who have motor deficits on one side of the body. They can't use their bodies the same way they used to, so over time, they stop trying. Let me give you an example of how it occurs. Let's say you have a stroke on the left side of your brain, so now your dominant right arm and leg have substantial weaknesses. The first time you start moving your body after the stroke, you don't realize what the deficits are. If you wake up the next morning after your stroke and breakfast is served, you're going to try to use your limbs the way you have previously. You might try to pick up your orange juice with your right hand, but because of the weakness, you might knock it over and spill it on yourself. So you start to get negative reinforcement for trying to use your limb. Then it might be time to use the toilet, and you're going to try to stand up with both legs as you always have, but now your right leg might buckle on you. Again, you get negative reinforcement. All the therapists and nurses are telling you to try to use your right side, but when you try to use your right side to feed yourself, it takes 45 minutes and you're covered in food and drink and you're not comfortable. It makes sense that then you would start to use your non-dominant functioning left side, because if you use your left side to eat breakfast, you're going to be able to eat in a reasonable amount of time, you're not going to be spilling things on yourself, you're not going to be knocking things over, and you're going to get positive reinforcement for using the non-affected side. What happens, in fact, is that you learn not to use the side that's affected by the stroke. It's very difficult to remediate learned non-use, but the technique we use is called constraint-induced movement therapy, which you may see abbreviated as CIMT. Question 31. What is constraint-induced movement therapy and who is a good candidate? Dr. Page. Constraint-induced movement therapy is a protocol that helps to overcome learned non-use with forced use. First, the therapist identifies tasks that are important to the patient and breaks them down. Then, as the patient becomes more proficient at performing the pieces of those tasks with the affected limb, the patient puts the pieces together. The second part of the program is to constrain the less affected arm, thus forcing more use of the affected arm. This is done by putting a padded mitt or glove on the good hand or by putting the good arm in a sling. Then the stroke survivor practices everyday tasks with only the affected hand or arm. It's been proven that when you combine these pieces, have people practice iteratively using the arm, force use of the arm when they're home, and provide strategies to encourage them to use the arm at home, like keeping an exercise log, it significantly improves arm function. Traditionally, CIMT is administered very intensively over a 2-week period, requiring people to go to therapy for 6 hours a day. There are a couple of problems with this. It's hard for patients to comply with the 6-hour-a-day regimen, and it's hard to get reimbursed by insurance. Fortunately, we can modify the therapy and get similar results. We can do the therapy in half-hour segments 3 to 4 times a week with lots of home practice over a 10-week period and get the same results as with the intensive program. This is called modified constraint-induced movement therapy, or MCIMT. You shouldn't just do this on your own at home. The therapist's guidance is important. Therapists can assign specific home exercises, check in on the progress of those exercises, modify them if they're too easy or too tough, and move forward from there. Ask your occupational therapist about whether it's right for you. CIMT does not work for every stroke survivor. The program takes only people who have a little bit of active movement in the wrist and fingers, specifically what's called extension, and only about 25% of stroke survivors get that back. I get calls from people all the time who say, I want to do constraint-induced therapy because it's well publicized, but in fact, it works only on the proportion of patients who have that active movement. It's a wonderful therapy, but as with any other area of medicine, we want to apply the right treatment at the right time on the right people.
4 years after my stroke, I was in a clinical trial for CIMT with Dr. Taub, who developed this therapy. At the time, his clinic in Alabama was one of the only places to get CIMT. Now it's available around the country. The treatment was very intense and very time-consuming. It helped my arm and shoulder a little bit, but not my hand. I'm glad I tried it, but it was frustrating. For me, I noticed a small improvement, but most survivors with less paralysis see large improvements. Every stroke is different, so it could be an option for you. David.
A tip. The human brain is one of the most wondrous and advanced entities in the universe. Each one is complex, and each stroke is different. The professionals treating you are experts in their fields. However, I also tell my patients this: only you are the true expert of you. You are the only one who knows what it's truly like to be in your body with this brain. Throughout this process, become the expert of what you need for an optimal recovery. Question 32. How can technology help with recovery of physical function? Dr. Stoikov. I'm a fan of low-tech technology. There are few things you can do to train the brain or trick it into working better. One is called mirror therapy. You place a mirror between the two sides of your body with the mirror facing your good arm, and you put the affected arm behind the mirror so that you don't see it. Then when you look at the mirror, you see the movement of your good arm, but your brain thinks it's the affected arm moving. You're tricking the brain into thinking the affected arm is making normal movements. You'd want to try this with an occupational therapist first to learn if it's right for you and how to do it at home. Another thing you can try with a therapist is called bilateral priming. I use something called an Exurgo bilateral priming device, but I call it a flapper. It's a device where each hand goes between two plates that are connected together so that the stronger wrist moves the weaker wrist in and out at the same time. I have my patients use it for 15 to 20 minutes before they do their occupational therapy, and I've seen a big difference between those who've done the bilateral priming and those who haven't. Dr. Gillen. We use bowling or tennis video games on consoles like Wii and Xbox to help people work on balance or limb function. It's very motivating to people, even older adults. The Kinect device for the Xbox doesn't even use controllers, so it's like virtual reality. And it's commercially available to everyone. There are various apps on smartphones that help with stroke recovery. For example, you can use apps to track home exercise programs. There's also a whole emerging world of telehealth or telerehabilitation that lets you consult with a therapist via FaceTime or Skype if you can't actually come to a therapy session.
There was very little technology available when I was in therapy, but the Wii was new. I really liked that the therapist used something fun to help with strength and balance, and that proved helpful as I was able to use it at home too. The occupational therapist used Velcro or an ace bandage to keep the remote in my right hand. Having fun can help you get through this process. Have fun, laugh, smile. It's great medicine. David.
A tip. Doing something fun is one behavioral element of cognitive behavioral therapy. When we're feeling low, it can be helpful to choose an activity that brings us pleasure, like playing a game with someone, taking a bath, or watching a funny movie. When we smile and laugh, the brain releases neurochemicals that improve our mood. This lightness goes a long way, especially when we're going through a difficult time. Another simple trick from the Buddhist tradition that has been shown to have powerful neurochemical effects on the brain: put a Mona Lisa smile on your face through everything you do. Lightly smile when you wake up. Smile through that difficult physical therapy session. Smile when you're having a hard day as a caretaker. It actually tricks the brain into thinking it's happy, which can release feel-good hormones and promote actions that lead to real, spontaneous smiles. Dr. Page, there's a new device called the MyoPro that's being successfully administered through the VA and is increasingly being covered by insurance. This electronic brace, created by a company called Myomo, is a myoelectric device, meaning it detects and amplifies the electric signals from the muscles to help the patient move. That's a really exciting development because it means someone can get a brace fitted to the affected arm and then use this device to help him or her do things at home, like flip a light switch, turn a key in a lock, get up out of a chair, or pick up a laundry basket. The device is affixed to the arm so it's portable, and it gives the extra help they need to perform valued activities. Question 33. What can stroke survivors do to make one-handed life easier? Dr. Page, an occupational therapist can help you identify adaptations. You might have to learn things like one-handed shoe tying or writing with the non-dominant hand. There are tools like one-handed can openers, reachers, and sock aids. One of our jobs as therapists is to educate stroke survivors on the use of this equipment to help them be successful and independent. The exact tools depend on the patient and where the impairments are, but there are adaptations available. Magazines like Stroke Smart have lots of ads in the back for one-handed tools to help stroke survivors.
Adapting to being one-handed was challenging. I worked on improving, but I had to work on adapting too. For example, I now have an automatic light that turns on when I walk in the room. I also have a magnetic doorstop for my front door that helps when I'm bringing in groceries. The lid of my trash can opens automatically when my hand waves over it. Work on strengthening your abilities as much as you can, and then use the tools where you need them. David.
A tip. Every human being has strengths and weaknesses. If you've had a stroke, these strengths and weaknesses may have changed. An approach that focuses on your strengths can help you be more successful in your life. So work with your strengths while simultaneously addressing your weaknesses. Stay honest, open, and willing through this process. What are your strengths today? What are the weaknesses you'd like to address? Takeaway points. The upper extremity is often slowest to recover because its movements are so complex, requiring a large area in the brain to control it. Keep using the affected hand and arm as much as possible in safe ways. Stimulate them with sensory feedback and continue to stretch. Watch out for learned non-use. Constraint-induced therapy can be effective for people with some movement in the wrists and fingers. There are tools to help make one-handed living easier. Talk to your occupational therapist to find out which ones are best for you, and also search online for one-handed products. Chapter 6.